Buongiorno a tutti, benvenuti a questa.
Good morning, anyone. Welcome to this main lecture. We're going to talk about the brain and the self. And I pass the floor to Professor Amore, who is going to introduce the speaker. Mario, it's up to you now. Leave it to you now, Mario. Thank you, Paola. I'm very pleased to introduce to you Professor Nordhoff.
Everybody. It is now my very great pleasure to introduce Professor Georg Nordhoff, which is really an opinion leader in the field of neural processing of self, and even a great friend of mine. He's a philosopher, neuroscientist, and psychiatrist. Being originally from Germany, he is now working in Ottawa in Canada, where he holds a Canada Research Chair for Mind, Brain Imaging and Neuroethics. Professor Nordhoff published more than 300 papers in international journals, including an important opera, Neurophilosophy and the Healthy Mind, translated in Italian language too. His research focuses on the relationship between brain and mind and in its various aspects, including neuroscience, psychiatry, philosophy. He is interested in discovering the neuronal mechanism related to consciousness and self in both healthy subjects and psychiatric disorders like depression and schizophrenia. His main area of expertise is the relationship between the brain and mind in its various aspects, as well as the most relevant biochemical underpinning and neurochemical mechanism underlying mental activity changes during consciousness and the experience of self. Further, he produced several papers by developing some bright ideas, very bright ideas, linking psychoanalysis and neuroscience. Now, his presentation will be on brain and self, symptoms and differential diagnosis. Please, Georg.
Yeah, thank you, Mario, and thank you for introducing and also inviting. I'm very happy. Obviously, I would have preferred to be in person, but it's great to be via Zoom also to see again. So buongiorno to everybody. Now I have to switch to English. Okay, yeah, I'm talking about, and Mario indicated it already, about a topic in psychiatry and psychopathology which is often neglected, particularly in the clinical diagnosis and therapy. Beneath, and you all know this as clinicians, beneath the surface level of the affective, cognitive, social, perceptual, and motor symptoms, you have a deeper level. And this is often pre-verbal, non-verbal, but you sense it as the experienced clinician. There's a deeper level, a deeper fundamental disturbance. In schizophrenia, for instance, Joseph Parnas speaks of a basic disturbance. And what is this deeper fundamental level? And that's, for me, the sense of self. So for me, at a deeper level, psychiatric disorders are self disorders. And interestingly, we don't really have a psychopathology of self, nor are any of the self different disorders in DSM or ICD in our diagnostic classification. But however, as you know, if the basement of a house is crooked, all other subsequent floors will also be crooked. So you need to change the basement and diagnose the basement to understand the upper layers. That's what I'm trying to do in my talk. So first, I will basically briefly introduce you findings from healthy subjects that the self is a basis function, the basic function of brain and mind, not, as philosophers told you, a higher order cognitive. It's not the pinnacle, it's the fundament or the basis. Then I will show you findings on the self in schizophrenia, and then the self in depression, and the self in anxiety disorders. And what I'm trying to do here is, let's say that each of these disorders has a specific change in the self on psychopathological grounds and on neuronal grounds. And ultimately, I will not have time to get into that, to show that these basic disturbances in self, these different kinds, then very well explain the symptoms, the differences and the overlaps in symptoms. So let me start with the first part here, the self as basic function of mind. So the self is a concept everybody associates everything with it. When I mean here by self is a very simple thing. So I see now myself here in the Zoom and I know, yeah, this is Georg Nordhoff speaking. Yeah, and particularly I recognize myself, but that recognition also goes with a certain feeling, an experience. An experience, aha, I am part of the wider room in which I'm standing here. Yeah, and that feeling, as you all know, as psychiatrists, can get lost. Yeah, in schizophrenia or in depression, it's abnormal. Everything is just focused on the self. I will come back to that, and so forth. So now, and of course, there are different layers of self. Yeah, you have your bodily self. The theories of embodiment point that out. You have your higher order cognitive self. I am aware that I am myself. Yeah, so I can recognize myself. And then there's also sort of a feeling, yeah, a deeper feeling of belongingness to you're part of the respective environment. You can relate to, for instance, when you hear music, you can synchronize with the music and yourself completely immerses in the music. We recently conducted, the former postdoc of mine, who's now professor in China, Pingming Qin, a meta-analysis of different aspects, layers of self. So you can see, for instance, first we looked for all kind of studies which probe internal organ function, your awareness of your heart, awareness of your stomach, awareness of your breathing. So, and interestingly, that's yielded regions. Here you can see this typical region, the key region is here, the insula. It's here on the right side, exactly I don't know whether you see me, my fingers are. So on the right side is part of the ancient limbic system. It's a bilateral insula, then you see also the thalamus. Then when you sort of more stimulate with your external surface of your body, proprioceptive stimuli, when you touch, for instance, yeah, then you have again the insula, but you also have other regions, like here the anterior medial prefrontal cortex. Now, then here you stimulate, you become aware of yourself. So you see your own face, you see yourself in Zoom, and you have to identify. They call this self-referential processing. The details are not important. Now you have these very typical regions in the midline called cortical midline structures activated. Now, put all this together and you get this. This is very interesting. So here, you're aware of your inner organs. So you have an awareness, you integrate your inner organs, the movement of your heart, of your stomach, and you literally see this when you see the little infant, that's what it is, yeah? So that's interoceptive processing, involves the insula. Then very interesting, the insula is activated again when you stimulate your body, when you touch your body, yeah? But then you have additional regions, yeah? And then when you become aware of yourself, so this is also developmental stages, as you can see, I don't want to get into that. Then you have again the insula, you have all these regions activated, you have this region activated and additional region. So your brain continuously implicates the former regions, but extends them. This is typical of what you call a nested hierarchy. Remember the Russian doles, a smaller dole is integrated within a larger one and so forth. Same here, that's why we had this very nice figure. And these nested hierarchies are key. I think they are key in understanding different self-disturbances and the subsequent symptoms in psychiatric disorders. And I will often come back to this nested hierarchy, and I hope that throughout the talk it will become clearer what I mean. That's the spatial dimension of self. Self has also a temporal dimension. Your temporally continues. So despite the fact I was the last time in Italy, actually in January 2020, and I'm still the same person. 1 year has passed, all this COVID craze and everything. I'm still the same person. So there's a temporal continuity of yourself. How is that possible? Maybe that temporal continuity is mediated by temporal continuity of your brain. However, you know the brain changes, but there may be in the fluctuations, the shape of how your brain fluctuates might be the same. So our brain continuously changes, fluctuates. You have fluctuations in very slow frequency ranges, which you can measure with fMRI, and in faster frequency ranges with EEG. Yeah. Let me see here. This is a typical model. So it's like waves. Our brain has big waves, small waves. You have all the Mediterranean Sea, and you see the big waves, small waves, and so on. Same thing in the case of the brain. Yeah. And what is important that we showed in various studies, and this is now replicated by others, that the waves, the shape of the waves between slower and faster waves is very important. Slower waves, as you know, have a lot of power. When you have big wave in the Mediterranean Sea, they smash you to the beach, whereas the small waves, the faster waves, are not as powerful. Same in the brain. You can see this, for instance, here, what we call a power spectrum. You have less power in the faster waves. You have more power in the slower waves. And the relationship of that, the steepness of this curve, that's related to your sense of self. Self-consciousness, which you can see here, we applied the self-consciousness scale. You can see, meaning the more the balance between faster and slower frequency tilts towards the slower frequencies, the higher your self-consciousness. And it's important, it's really the balance. It's not just one frequency, it's a balance between the frequencies. We could show this in EEG, faster frequencies, 1 to 50 hertz, slower frequencies in fMRI. So really your self, and that's our model of self, is a basic function. And it can be described in spatial temporal terms, like the power spectrum, slow, fast waves, the regions like the nested hierarchy. And you will see the spatial temporal characterization, that's what I assume is altered in different ways in different psychiatric disorders. And you will see that the way I structure my talk. So that's why we speak of a basis model of self-specificity, and we're constantly updating that. And that's here is the basis in terms of spatial temporal schemata, and that determines your sensory, your cognitive, and your affective functions. And I will try to point that out a little bit. And that's why if you have slightly different changes here, you have slightly different symptoms here. Yeah, and I think that, and you also have a certain overlap, and that's what we see in psychiatric disorders. Yeah, so basically, you see, I'd like the comparison. You see here, I have the comparison of the self with nature. So it's like waves, it's a relationship between slow wave and fast waves. Slow waves are more powerful, fast waves are less. And yourself is basically like a surfer. It surfs on these different waves. It can integrate different scales of the wave, slow wave, fast waves. Yeah, that's the ingenuity. And maybe in psychotic disorders, this integration between slow and fast wave is abnormal. I'll show you data on that. And the other example I show you, which is of course even more closer to home, is Leonardo da Vinci. I'm a big fan of him. You can't imagine. Because for me, when you look at his painting, he has a 2D canvas, but it looks like a 3D. Of course, you know all this Milano Last Supper. And when you look at the apostles, you know, of course, one of them will be the traitor, but you have the feeling it's just a snapshot. If you would look at the painting in 1 millisecond later, you would have the feeling the gestures is different. So he constructs a temporal dynamic. Look into the Mona Lisa or other painting, always in the background in Da Vinci's painting, you have a river flowing. You have the feeling there's a river flowing towards the person in the foreground. Unbelievable. It's how he did this, I have no idea. But that's what our brain does. Yeah. So that's basically the idea. I showed you self, basic function, spatial temporal features, and it's your brain spontaneous activity. So now I want to go, first I start with the self in schizophrenia. You all know, and beautiful descriptions, phenomenological descriptions by Joseph Parnas, Louis Sass, and others about basic self-disorder in schizophrenia. And basis means here, it's a phenotypic trait marker, so it persists even in the absence of acute symptoms. Yeah, so, and it's a basis for and prior to the different symptoms. Yeah, and Parnas speaks in a paper also about the self-world structure, confusion of internal self, external world, and you will see that will be key for me in understanding this basic self-disorder. So let me start here. So here, very recently, just I think it was published in January in Schizophrenia Bulletin. So here I reviewed with a very clever postdoc, he's an engineer actually, Javier Gomez Pilar from Spain. He did fantastic work on EEG and schizophrenia, and I saw that. I said, let's put this together. So in your brain, what we usually do, we probe the brain with certain external tasks or stimuli. You have to calculate something. You see, let's say you see a stimulus with the Colosseum in Rome, or even better, you see a nice photo with a lot of good Italian food. And however, the brain, and then you measure the activity during those external stimuli and tasks. However, data have shown that also what happens prior to the external input is of relevance, called pre-stimulus, and then also the resting state. So here you still have neuronal activity going on, but not targeted towards a specific external input. So that's probably your internal ongoing thoughts. While you listen to me, you just say, okay, I'm not really interested in this Nordhoff guy. He's so metaphysical. I don't want to hear this. I just pursue my own thought and think about how I make the next nice dinner, or I go to the next opera, hopefully if the COVID will allow me at some point again, or something like that. Yeah. So meaning you have your internally oriented cognition maybe going on here, and maybe here you're externally oriented. So, and what is important, usually we have a change. So usually you have a change here from pre-stimulus or resting state to task, because that makes a distinction. So your ongoing thoughts are suppressed, put in the background, and now you look at me, because I really try to wake you up. You look at me, so you cannot avoid of just suppressing your internal thoughts about your opera and your food, and just follow me. Yeah, and what we could see here, this is, I don't want to go into detail, that the schizophrenic patients do not change their activity during this period. So basically, they do not properly process the external input, and their processing of the external input is overlaid, is too much suffused by the ongoing internal activity. Yeah, so, and you can see this here. So you see the blue line here in all these things. These are different measures of in EEG connectivity. You see the blue line is the healthy subject, how much they change from pre-stim to rest. And you see they either decrease or they increase. Yeah, it's a relative change. And you see that here the longer arrow is the degree of change in the healthy subject. But in depressed subjects, in schizophrenic subjects, they basically don't change. Look, the red line is not much change, it's just the same. So they do not properly react to the external input. They cannot change their ongoing activity. Here, we showed this for various EEG, fMRI studies, did a review, presented some own data. And here you can see this. Independent of whether your pre-stimulus or resting state activity is too low or too high, they don't change. Look, this degree of change here, this little thing, is much smaller than this degree of change in the healthy subject. On a cognitive level, this means that your ongoing internally oriented cognition cannot be properly distinguished from the externally oriented cognition. So what do you do in psychodynamic terms? You start projecting. Yeah, you perceive the external input, the external event in terms of your internal thoughts. And I think that's really close. So you have a confusion between internal and external. Yeah. So then, of course, the question is, why is there such a reduced rest-task differentiation? Maybe that is related to what we call to temporal integration. Meaning, if your wave from the pre-stim is too big, it basically swallows the next wave. That's your external input. That's the idea, temporal integration. So let's say if the wave is too long, it will swallow all the smaller waves, and you cannot see the smaller waves anymore. And that's exactly what seems to happen in psychiatry, in schizophrenia. So here we again just very recently published a study with Joseph Parnas together, and we had the fantastic opportunity to get EASE data from the basic self disorder as well as EEG data, doing a paradigm specifically on self. So people had to basically recognize their own self while it was face, while it was morphed. And I know this is difficult to see. And again, what we see here, so we measured temporal integration by different measures. So how much one activity point correlates with the next each other from pre-stim, resting state, and task. So, and we call this autocorrelation window, or power law exponent. It describes the shape of your power spectrum. And we could see that in schizophrenia, the patients do not decrease their temporal structure. They basically carry over the temporal structure of their neuronal activity from rest to task, and it's too long. So they integrate. Here you can see here you can really see a rest task change, the relationship between this changes in the healthy subjects, but here you see the same relationship for rest and task. So meaning what you have in schizophrenia, that's what the data show. Here, let's say this bigger Russian doll too much impinges upon the smaller Russian doll. This is your internal ongoing activity. This is your external input. And the small one is barely visible, whereas in healthy subjects, this might stick out much more. So basically, the long frequencies, the long cycle durations in the schizophrenia from pre-stim and rest are carried over to the external input, and then you perceive the external world in terms of your internal cognition. Psychodynamically, it's called projection. Psychologically, you have a confusion between internally, externally oriented cognition. And as I said, that probably also happens on the level of the brain, that you have reduced difference between pre-stimulus / resting state activity, internal cognition, and external activity, task states. So now, of course, next step is maybe we can substantiate that further, link that to a specific mechanism more better, and then maybe induce some therapy, makes them more reactive to external stimuli. Yeah, interestingly, that was also related to psychopathology, because we could see that the relationship between basic self-disorder diagnosed with the EASE scale from Parnas and to negative symptoms, that transition was mediated by the time scales of your brain. So basically, the time windows of your schizophrenic brain are abnormal. They swallow the smaller time windows of the external input. Yeah, so that basically the main disorder which we assume here in the case of schizophrenia is really confusion between internal, external cognition, perception contents, and that is mediated on the neuronal level by rest / pre-stimulus and task-related activity with an abnormal temporal integration, that basically the external input is swallowed by the long time windows of your ongoing activity. And my hope is that we then maybe shorten those time windows, that the external input can be better and more separately processed from the ongoing activity. Now, so the basic disturbance here is the lack of differentiation between internal and external cognition. Now I go to the next one, to depression. You all know this. Read the quote, it's a beautiful quote. I will not read it, but you know this. And typical for depression is that they completely focus on their own self. You all know this. Everything is around the own self, but I'm guilty, I'm not worth it, negative emotions. And, you know, Freud has a beautiful description of that. And then you have the circulating thoughts, ruminations, while you're completely detached and withdrawn from the world. So we conceptualize it as an increased self-focus, decreased world focus. So it's basically yourself is too dominating over your relationship to the world. So the question, where does this come from? So now you see, let's go, the first thing, let's go into the spatial topography or the spatial organization of the brain. So this is a beautiful paper which Andrea Scalabrini in Milano, a postdoctoral student of mine with whom I work long together, and he's also both. He's a very good neuroscientist, and I'm sure he's also a very good psychotherapist because he runs a psychotherapy praxis 1 or 2 days per week. So, and we work together. It's a really nice collaboration. And so Andrea Scalabrini did a fantastic paper here. So the idea of his was, we know that the regions in the middle of the brain, here, these regions, cortical midline structures, are associated with the self. Remember, I showed them before you, the third level of the hierarchy, the mental self. But maybe because of this increased self-focus, maybe these regions are too strong in depression. And that's exactly what has been shown in many papers. But what he now shows, he shows that these regions are not function isolated. They function in the brain global context. So you have a global brain activity, and that is too strongly represented in these cortical midline structures. Let me give you an idea what I mean. So this is climate change. You know that climate change has one source, meaning that not only one source, but you know this, the ozone, too much ozone output, and that's basically one source is a global source which applies to all. However, the manifestations of that in different countries are different. Yeah. So in some countries, they're more strongly affected, other countries are less affected. So same, and as you see, I'm not a Trumpist. So here you see in the case of the brain, same thing. So you have a global brain activity, which you can measure in fMRI, which what is called the global signal. And then you can see the degree to which that global activity is represented in single regions. And what you see here in the depression people, that this global activity is way too strongly represented in these cortical midline structures, the default mode network, which are associated with the self. You can see this here. So meaning there's way too much representation of the global brain activity in the local regions of the midline region. And of course, then you balance between, let's say, yourself and your perception and your cognition and all your other function is completely shifted to the self. So then Andrea Scalabrini did yet another very ingenious idea he had. Then he said, okay, if my global activity is too strongly represented in the midline structures of the default mode network, then how about the relation of the DMN to the other regions? Then it should be maybe that these other regions outside the DMN are too strongly connected to the DMN. Yeah. So it's basically, and that's what you can show here. So you see this, these are all the regions in network, and he correlates the default mode network regions with the non-DMN, and he says too strong correlation compared to the health side. So meaning your, let's say, your visual cortex is too strongly connected to the DMN. So then, of course, you perceive all the visual input in relation to your DMN and to yourself. Yeah, you have no self, no chance. Psychodynamically, people call this introjection. And Andrea speaks, and this is really, I owe this to him, he speaks, it's like a magnet. The magnet is too strong and it enslaves all the other non-DMN networks. And I think that's what you literally see. Everything is perceived in terms of the own self. Yeah. So you see, it's again a different mechanism than in schizophrenia, where you have this confusion between internal, external, and self and non-self. Here, you have that the self pulls the non-self to itself. And I can only say again with Andrea, it's too strong of a magnet. Yeah. So then they say, where's the temporal dimension? So another line. So we focus here on the occipital cortex. One key experience phenomenologically in depression is, you know, that they are too slow. Everything is, they are too slow. They cannot follow. The external world is too fast, has beautifully been described by Thomas Fuchs. It's too slow. Giovanni Stangelini also did excellent work on the phenomenology of this. It's too slow. I'm too slow. I cannot follow. And yeah, so we asking ourselves, maybe this experience of abnormal slowness, maybe it's related to abnormally slow activity in the brain. So here we focus particularly on the visual network. And you see, maybe here the occipital cortex region, and this is again data from Andrea Scalabrini. This is data from this is fMRI. And we can see in both modalities that the neuronal activity in occipital cortex is too slow. Yeah, so and that's what you see in depressed patients. They cannot follow. The external world is too fast for them relative to the inner slowness. So here we show, and we're just about to put this together in a large paper, that the occipital cortex itself activity is too slow. You can see this here in fMRI, we showed this, and here in EEG, you can see what we call the median frequency. Is the power spectrum illustrated here is too much shifted towards the slower frequency. So imagine your C wave, you just have some big waves, slow waves, but you no longer have the faster waves, which bring some life. Yeah, so that's basically the inner mental life of a depressed person. And these big waves reoccurring circular on the Mediterranean Sea, that corresponds to your reoccurring thoughts called rumination. Yeah, and you don't have any distraction by some faster waves in your Mediterranean Sea, and you look at it, oh God, how stereotypical, always these big waves, repetition, always the same. I don't need to tell you, that resembles the situation in depressed patients. And here we can see this on the neuronal level. So your occipital neuronal processing is too slow, and then every input from the external world is also processed too slow. So you're temporally decoupled because the external world is faster. Yeah, so and that's exactly, I show you, this is another study just last year from our self-powered, time is of essence. And here I show you that on the psychological level. This is very interesting because here we measured the early traumatic life experience with the standard scale CTQ, childhood traumatic questionnaire. And as you all know, in major depressive disorder, subjects had too high early traumatic life event. Now, then we wanted to see whether it is the time, and then you had also changes in your time perspective measured with this Zimbardo time inventory. It's down here. You have too much focus on the past, not enough focus on the future. You all know this clinically. But now we were asking ourselves, what is first? Is the time perspective changes a consequence of the depression? Or is the depression severity a consequence of the time perspective? And interestingly, this one holds. So you can calculate it with mediation model. So you have early traumatic childhood. It might or might not change your time perspective. You focus more on the past, and then you develop depressive symptoms. So even, it's not the other way around. It's not that the time perspective changes a consequence of depressive symptoms. It is this way. And that really says the key importance of time and temporal structure, even on the psychological level. And as you see, I try to project that, do the same on the neuronal level. That's why we speak of spatial temporal psychopathology. So when you put everything together, you have in depression an increased self-focus, decreased world or environment focus, and that is probably related on the spatial topographical side, that you have too much pull towards the DMN. As Andrea Scalabrini says, the DMN acts like an abnormal magnet for the rest of the brain. And I think that's exactly what these people experience. It's like a magnet, and they have no choice, and that's of course automatic, to control it. Yeah, they cannot escape this inner magnet, and they don't know. So when you have and that is probably, and that makes your whole brain activity, like also non-DMN, like vision, too slow. That's what we observe. So then you see, remember I showed you this nested hierarchy at the beginning. So now you have the mental self, the ring is abnormally large. Yeah, your mental self is so strong, it dominates everything, you cannot escape it. Yeah, whereas, and that of course then diminishes your other self, let's say, the external body processing, it becomes small. So you see that the nested, the different Russian, the size of the Russian dolls inside become abnormal. So next one, anxiety disorder. Very interesting case. I don't need to tell you that, you know, the abnormal often, when you speak, let's say, of panic disorder, the abnormal focus on the own body or the abnormal focus on external world, social anxiety disorder. Yeah, and remember our schema where the insula took a key role. The insula was in all different layers of the self. So interestingly, and that is expected, also published last year, we showed that insula shows hyperactivity. You see here the gray bars as a generalized anxiety disorder people in response when you have to monitor your own heart. They show hyperactivity in the insula, which of course makes perfect sense because that's exactly what you see clinically. You see an abnormal focus towards your own body. They basically, now here's a magnet, is not the DMN, the magnet is the insula, and it pulls all your attention towards your own body, and you cannot avoid it. So your perception of your heartbeat changes, becomes much more sensitive, fine-grained, and then of course you get anxious. It's very normal that you get anxious. Yeah, you hear it pounding, it's normal, but you perceive it in a much more fine-grained way, sensitive way, and then of course you get anxious. I would get anxious too. That's probably related to hyperactivity in the insula. And here you show this, here we show that the hyperactivity of the insula is then also related to your awareness of your own body, which of course makes sense. It's an awareness scale of the body perception questionnaire. And here you see also the Hamilton Anxiety Somatic Score, meaning it's become higher the less different. Then here, very interesting, we also showed that the insular hyperactivity has decreased relationship to the medial prefrontal cortex. So meaning your body self takes over and is no longer properly related to your mental self as here in the midline regions. That's really, you can map that. And that's your shift. You have abnormal focus on the body self, but no longer really self-awareness on the mental level. So where does this all come from? Maybe we put this, as just came out, that what you see, maybe it's related to abnormal synchronization of brain and heart, for instance. So here we show that your insula, maybe it can no longer, the insular rhythm can no longer synchronize with the heart rhythm. So what happens when you dance to music and you have the feeling you can't synchronize anymore? You get anxious, you worry, oh, I want to keep up with the rhythm of the music, I want to go with the rhythm of the music and dance to it, but I can't get there. So you get, over the time, you get more and more nervous. Same here. If your brain cannot synchronize for whatever reason with the rhythm of the heart, then of course the brain gets nervous. You want to get into that, yeah? And then of course you develop anxiety. So that's the idea here. It's the brain-heart desynchronization, out of step, and there's indeed substantial empirical support for that. And what does this mean now in terms of yourself? So again, abnormal nestedness, and you can see now your body self becomes abnormally large. Yeah, so it predominates over the other layers of self. So again, one Russian doll is taken out, abnormal size, your body Russian doll, and the other ones are diminished. So it's a disbalance here. Summary and conclusion. So here, the healthy self, and that's really supported by the neuronal data, you have a balance. You have a balance between your internal oriented cognition, between the input from your body, your bodily awareness, and your externally oriented cognition. We usually somewhat in a balance. Of course, it fluctuates back and forth. And that balance, that integration is probably what we call self. And it also has a time component to it, meaning it's a balance between slower and faster frequency. Your external input, of course, very fast here. When I do this, you really have to follow. But your bodily input might be slower. Your breathing is a little slower, which I didn't indicate here. And then your internal cognition are even slower, a little bit more sluggish. So it's a multi-scale organization. And the integration of these different scales and also spatial domains, that's probably yourself. And that happens all, and that's very important, outside your consciousness. Happens prior. It's completely automatic, it's dynamic. That is like the waves on the seaside, you cannot impact them. That's the way it is. Yeah. So now, in schizophrenia, it seems that this distinction between here you see I plotted here, there's a certain difference, you can distinguish them. In schizophrenia, here you apparently cannot make the distinction anymore between your inner self and the external world. They're too close because you can't change your activity anymore. Yeah, your pre-stimulus is basically just your resting state, it's just an autopilot. Your stimulus is somewhat external input, somewhat processed, but it's very processed in a minor degree so that it doesn't really become aware. So what is aware? So then you get sort of a mixture between your external input and your strong internal input, and what you become aware of your experience then is the mixture between the two, and that the psychiatrist calls this delusion. Yeah, the schizophrenic brain would probably just say, yeah, I cannot properly separate the rest from the task. Now, depression, remember the magnet, what Andrea Scalabrini said very beautifully. So the magnet is too strong, everything is tilted towards the DMN. You see here now the internal cognition is too strong. Look at this. Now look at this arrow is much bigger, and that's probably mediated by your abnormal DMN. And then, of course, nothing is for free, as we all know. So meaning your awareness of your body and your awareness of the external world decrease. Yeah, nothing is for free. Then here in anxiety disorders, so here you see it depends on here now, suddenly the heart, remember this is the original one, this now here the heart is too strong. Yeah, so you have abnormal awareness, like in panic disorder, you have the feeling you die of a heart attack, and the internal medicine people can't find anything. And finally, they also desperate and send you to the psychiatrist. Yeah, so and in social anxiety disorder is the other way around, and that here your externally oriented cognition for specific task is increased. And actually a student of mine in Italy, in Florence, Lorenzo Lucerino, he really showed this, that the activity here during social stimuli is too high in particular default mode network regions. So I come to the end, second to last slide. So what is new here? It might sound strange what I'm doing. I try to uncover a more basic dimension of our psychic life, the self, which I deem to be central in psychiatric disorder. That basic dimension, the fundament of our psyche or mind, is disturbed in these disorders. And I showed you, and that means, and it's disturbed in its spatial and temporal coordinates. Yeah, on an experiential phenomenological level. And I say that these temporal spatial coordinates, the abnormalities of this, can be found in analogous ways in the brain. So what I say, it's a spatial temporal view of the self, and ultimately what we need, what I call a spatial temporal psychopathology, complemented by what I more recently developed, a spatial temporal neuroscience. So, and I hope that some of this, and I try to indicate a differential psychological and neuronal patterns of the self in different disorders. And I hope we can enlarge this, and that ultimately we can include this in psychiatric disorders, because my hope is this will allow you a better differential diagnosis. And secondly, maybe also better treatment, because if we treat the basement of our brain and our psyche, maybe we have a chance of better treating the upper layers, the affective cognitive symptoms. So, and with that, I conclude, and you see here, the really key point is on a psychological and neuronal level, the code is time and space. Temporal spatial dynamic is the brain code, is the self code. And you see a recent book which just came out, Il Codice del Tempo, with Il Molino, and I really need to thank my editor, Daniele Malaguti, for that. Just came out in February, for having the idea of this beautiful title. And there I really say the brain and its relation to world and body, it's time. Time matters. Thank you very much for your attention.
Thank you, Georg. Thank you very much for your excellent presentation and for your studies and your bright ideas which open new frontiers in the research in psychiatry. Il simposio è finito. Io passo la parola alla professoressa Rocca per la conclusione del simposio.
To close this symposium.
Thanks for your excellent report. Allora, abbiamo chiuso la seconda lettura magistrale, ringraziamo tutte le persone che sono state con noi.
The key lecture. We would like to thank all the speakers who joined us in
relazioni.
this
Intanto
session.
voi
And
usciti di qua ci sono già degli altri simposi.
And there will be other symposia that you can join.
And see you later. Okay.
See you later.
Multe grazie. Thank you so much. All the best.